welcome to Your Health in Your Hands. I'm Dr. David Ajibade with the Brain and Body Foundation. Now, you probably know this already, but problems with the bones and joints are probably among the most common things that people go to the hospital, especially if you're over 50 like I am. So, as a matter of fact, and I believe our guest today is going to correct me if it's wrong, but low back pain is the number one cause of disability around the world. Now, if it were a psychiatrist, probably he would say it's mental health issues like depression is the number one cause of disability. Well, we all know what the truth is. I mean, I started feeling it seriously myself. As a matter of fact, I gained a lot of weight while I was in the US, and then eventually I found a squash courts. I found a gym that I felt I could play squash at. I was so excited. After gaining all that weight, I just jumped right back into the squash court and I started playing like I was 20. Of course, you know what happened. I eventually injured my knee, and for the past 2 years, I've been hobbling around. I mean, it's gotten a lot better. I can still play, but the pain is still there. So what we're going to be talking about today is probably going to be of importance to you. And I hope you can take some time out to listen to this and call your neighbors, your friends, to have them listen to this talk about the human skeleton, your knees, your joints, your bones, and what you need to do to protect yourself and to keep yourself healthy from a very special guest today. So I am going to introduce him, and he's going to say a few things about himself and what he's doing. And so thank you, Dr. Julius Oni. You have a middle name there, which you talk about.
It's yeah,
okay.
Julius Kunleoni.
Dr. Julius Kunleoni. Welcome to the show, sir. Tell us about yourself. Let us know the good things you're doing in the world and in Nigeria.
Thank you so much. I really appreciate the opportunity to come on this platform and speak with you and speak to the audience. My name is Dr. Julius Oni, just like you said, and I'm an orthopedic surgeon and investor. But I guess today's conversation is going to be mostly focused on my orthopedic surgery work. So I was born and raised in Nigeria, and left after high school to start college. And when I say start college, I mean start college in the US, right? So I left in 1999 to start college in upstate New York. And then very shortly afterwards was admitted to medical school. I was lucky to get into medical school at Howard University in Washington, D.C. Soon after that, I mashed in the field called orthopedics. And that's the surgery of muscles, bones, and joints, if you want to think about it that way. But the story that led me to doing orthopedics in the first place, I think it's important to highlight, because I actually went into medical school thinking I wanted to be a cardiovascular surgeon. But a conversation with my father about my paternal grandmother changed all of that, because we were having a conversation and we were exchanging pleasantries, and I asked after my grandmother, his mother, and he said, "Oh no, she's having quite a bit of a hard time with the knees. She's having a hard time, walking and doing the things that she loves to do on a daily basis." And she was diagnosed with end-stage knee arthritis. That's severe arthritis of the knee. And so I was wondering, why couldn't that be fixed easily? And even at that time in Nigeria, my father told me that, it's difficult to find anyone to essentially replace her knee or fix her knee at that time. So that started a cascade of different events that eventually led me from being focused on being a cardiovascular surgeon to essentially pursuing the world of orthopedic surgery. And so I was fortunate to train in one of the best places in the world to do it. And after that, got into a fellowship at Rush University Medical School in Chicago and trained specifically to replace people's hips and knees. And over the last 11 plus years, I've been a consultant, orthopedic surgeon. And the first 3 of those were spent in Philadelphia at Einstein Einstein Hospital. But that hospital is actually now called Jefferson Einstein, and it was while I was there that I was recruited by Johns Hopkins to, that's where I've been for the last 8 plus years. So currently at Hopkins, I'm a associate professor of orthopedic surgery, and I also am the director for global orthopedics at Johns Hopkins. So in the last several weeks, specifically about 6 weeks ago, I took a leave of absence from Johns Hopkins and came to Nigeria because I wanted to bring as much impact as I could to improving access to care in Nigeria. And I wanted to do everything that I could to improve the quality of orthopedic surgery care, particularly joint replacement care. For orthopedic surgery and musculoskeletal care in general, I wanted to do my part to improve this. I had been coming over the last 10 years, on and off a few times a year to deliver services either through our nonprofit Operation Stand Walk Run or through other boutique hospitals, collaborations with boutique hospitals like Cass Hospital and others. But I didn't feel like we were able to move the needle fast enough. So, or create impact at the scale that I wanted. So, I felt it was going to be important for me to take significant time to come on ground and do some of this super impactful work. And so far, so good. It's been a whirlwind of events, but it's great. I've seen my first series of patients. I've operated on my first series of patients, and they're doing well, thankfully. And I expect to continue to expand the work in the weeks and months and to come. So that's in short who I am and what I'm doing here, and I appreciate the opportunity to be here today. Thank you.
Absolutely. So I want to say talk about a few things now. I mean, one of the things I found most striking about orthopedics, especially among women, and this is a statistic that you can confirm for me. If an older woman has a hip fracture, and she has admitted for treatment, there's a 25% of them will not leave the hospital alive. In other words, they will die during or after treatment, but they will not leave the hospital. How true is that statistic?
I'm not sure exactly where that statistics came from. We do know that the mortality rates within the first year after a hip fracture in elderly people is very high. I think that statistics is closer to what the mortality rate within the first year after that hip fracture is for the patients. But I don't think it's within the same admission. I would highly doubt that. At least we're in a place like the U.S. I don't think that is the truth. Now I don't know the specifics for Nigeria at this time, but I think the key element to take from that is just that the mortality rates after a hip fracture are very high. No questions.
Why is that so? It's a simple fracture. In our minds, it's a simple fracture. Why is it that the rise rates are high?
So it's not a simple fracture. You want to know why?
Why?
When someone falls, right, and they break that hip, they actually become very deconditioned very fast, because usually if they fall and break their hip, particularly in a place like Nigeria, it may take a few days before they get fixed, right? If it's taking a few days before they get fixed, guess what? They are now at a high risk of blood clots, DVTs.
Right.
Right? Absolutely. They're now at high risk of developing bed sores. So all these diseases are recumbency, right?
Right.
So, but let's even take it away from Nigeria. Let's say a place like the US. Yes, they have had this fracture. This is a massive physiologic hit for an 80-year-old or 70-some-year-old. Their physiologic reserves wasn't what it was when they were 60 or 50 or 40s, right?
Right.
So,
Right.
so, so typically, this is a big physiologic hit, and now their body has to respond. Now their heart has to respond, to the loss of the initial loss of blood, and their muscles has to respond after they've been deconditioned for a bit, and they're trying to recover from it. So all of these things, and sometimes also if you want to think about it, by the time people start falling and having these fractures, sometimes there are underlying medical issues that are predisposing them to this falls, right?
Right.
And
Right.
that now sometimes exacerbate over over the next 12 months. So this, a lot of ways to think about it, but hip fractures,
Yes.
they seem simple, but they are not
Yeah.
necessarily. Oh, by the
And
way,
also, yeah.
the process of fixing them also can, once people develop those DVTs, now they
Deep
could
vein
easily throw
thrombosis.
a clot and deep vein thrombosis. That's the blood clots. They could
Yes.
now have a PE, pulmonary embolus, which could cause people to die just like that.
That's a good point. And you mentioned physiological hit or impact, meaning that the body has to suddenly have to marshal its resources to combat that shock to the system. But there's also another aspect, because I deal with the brain so much. The whole people who maybe they were already beginning to have lapses in their memory or in their cognition, that is a hit that can tip them over into full-scale dementia. Another conditions that they probably would not have had to deal with if they didn't have that fracture.
Yeah,
And
it's
so
not
that's
just a fracture. It's not just a fracture that tips them over. It's the combination of the anesthesia that is required for the surgery. Right? Yeah. And some of the medications that are required to control the pain around the time of surgery. Yeah.
Got it.
You can add that to it. Yeah.
Thank you. That's a really good point. So there's a constellation of factors that really end up increasing the mortality rate, and of course the other, shall we say, the other conditions like dementia and even heart disease, and of course risk of having stroke, risk of having a pulmonary embolism, which is clot lodged in the lungs, and the arteries of the lungs are shut down the lungs and can cause all kinds of problems. So yeah, that's very interesting. All right, let's talk about, because you mentioned your grandmother osteoarthritis, and that's kind of like what's, shall we say, shifted from cardiothoracic surgery to orthopedic surgery, which probably was a really good idea, not just for the maybe for the shall we say, your mission-centered life, but also in terms of lucrative. This is orthopedic surgery, lucrative business. I'm sure you considered that as well before making the shift. Well, let's not go into that.
Well, yeah.
Go ahead. I was just kidding.
Cardiothoracic surgery was pretty lucrative too at that time, at least. But yeah, I didn't necessarily think. Actually, I considered a lot of things. I considered family medicine. I was actually not thinking much of how lucrative the fields were going to be, because I mean, I was a poor medical student. Anything that I was going to make after graduating was going to be a great graduate. It was going to be a fantastic upgrade from what I made, which was zero at that time. So, but yeah, you're absolutely right. Choosing orthopedic surgery was a fantastic financial decision too. But I didn't think of it as that at that time.
I think you made the right choice. All right. So let's talk about osteoarthritis now. Obviously, not everybody's. Some people will say, well, I'm just going to keep using my knees anyhow I want to. I know when the time is right, I'll get a knee replacement. A lot of people over here in the US can afford to say that. Obviously, most people in Nigeria can't afford to do that. And unfortunately, many of them do come down with severe knee problems and hip problems. So what can they do? I mean, okay, yeah, reduce weight, but it's hard to do when, especially if you're from Ekiti like me, when everybody's eating pounded yam, right? I don't know where you're from, Makule,
Well, my father is from Ileology. My mom is from Ile-Ife, but I grew up in Ikare Akoko, Ondo State. So,
yes.
Ondo State, Ocean State, is
So,
of my
so you're not
origins.
so you're not unfamiliar with pounded yam and all the other good
No,
food that we
no, no. That's definitely a go-to for those state people.
There you go. There you go. So
Uh,
I mean, so yeah, it's hard to do. So what can we do? Are we just going to resign ourselves to our fate? What if we don't have good? Let's just say, I mean, if I mean, my father's a bit overweight too, so I guess I have some of his genes and all that, and of course
I
he has
mean,
a few he's struggling with knee problems as well. But
I mean,
what can be done? I mean, I just refuse to resign to the fate that, oh, because your parents have it, you're going to have it. Or I mean, there's got to be something people can do.
absolutely. I do. I mean, just along the lines of what I said earlier, certainly losing weight is one
Yeah.
for sure,
Uh-huh.
right? And losing weight is like most is 80% nutrition and diet and 20% activities, exercise. So if
Yeah.
you can watch the calories, know the type of calories you're intaking, and eat the right things, most people can lose weight just by just doing their normal activities, right? That's one. Even though it's a challenging thing to do, I'm not trying to, poo-poo the challenges associated with losing weight. Another thing is just to some people love to take things like glucosamine, chondroitin sulfates. Which the easy way to describe those are like they essentially act as joint vitamins, if you want to think
Uh-huh.
about it that way. There's
Okay.
the literature on them is relatively good, and usually they have minimal side effects, and I don't discourage my patients from taking those if they wanted to. Um,
But
and
have you seen any improvement yourself? I know you have been a traditionally trained medical doctor. You
mhm.
typically do not recommend supplements, but have you seen any interesting stories in which your patient
Oh
may
yeah,
be
definitely. I would say
okay?
50% of my patients swear by them, and
Uh-huh.
the other 50% says it didn't do anything for them. So that's why usually I still encourage it
Uh-huh.
whenever patients want to try them. I'm like, go for it. If it works,
But
if you want to.
objectively, have you seen any improvement from using the? I know there's research papers there, but I'm talking
Yep.
about in your practice. Have you
In my
seen patients
practice,
improve?
oh yeah, definitely. No, that's what I'm
Okay.
saying. The improvement is really recorded through the patient's reporting back to us, right? I mean, the patient could still continue to have arthritis, right? Because
Mm,
arthritis is not going to reverse. This
okay.
medications don't reverse it. But
Okay.
but if they don't feel pain anymore, if they
Yeah.
feel better, if they're able to get back to their previous levels of functionality, then guess what? That is a win. Like
Okay.
all of the non-operative treatments that we do use to help patients are typically used to mitigate pain, alleviate pain, and improve functionality for as long as they can. And when they stop working is when we start saying, okay, you got to consider surgery. Things like physical therapy, things like, using an assistive device like a cane or something like that to protect the affected leg. Things like anti-inflammatory medications, and it's a variety of them. And we do recommend them, but to be used judiciously. One thing I've noticed so far in Nigeria is there's a bad incidence, there's a significant incidence of like polypharmacy. Almost every patient has got like a bag of medications, and very often you find multiple anti-inflammatory medications in that mix, you know? And usually I try to educate them to make sure that they are not combining all these anti-inflammatory medications, because then they can really cause significant side effects.
Yeah.
But certainly anti-inflammatory medications is still one of the modalities that we use to control the pain that people develop, especially in the earlier phases of osteoarthritis. And then you can move on to the non-invasive procedures like injections that we do. There's the viscous supplementation, which is essentially a synthetic version of hyaluronic acid. Hyaluronic acid is a building block of cartilage and joint fluid. And so they essentially have a viscous fluid encased in it. And that is then injected into the knees, and it works for 55-60% of patients. So we usually would, and when it works, it actually works really well for them. You know, so that's that. And then there's steroid injections, cortisone injections, which are anti-inflammatory injections. Just think of taking an anti-inflammatory, but just limited to the knee, that we're just able to inject into the knee. And those actually work about 80 to 90% of the time, but the duration of their efficacy is less predictable. So, but you know, and all of these things that I mentioned, weight loss, anti-inflammatory medications, viscous supplementations, injections, using a cane, physical therapy, and all other modalities that exist to treat pain non-operatively, they are all temporary measures to keep the pain away, protect the joint for as long as possible. But and sometimes the arthritis does, you know, even though it waxes and wanes, even though sometimes it progresses and then it stops for a while and progresses and stops for a while. And some people, it doesn't progress all the way to end stage arthritis before they expire. But for some people, it does progress all the way to end stage arthritis. And then they start becoming very debilitated. And now they can't really do the things that they love to do. Now they're having to think around their knee and what to do with their knee before they can do anything. They're calculating the distance based on what their knee can tolerate.
Yeah.
You know, once that starts to happen and all the non-operative treatment is failed, then we do offer joint replacement, which is when it comes to severe arthritis, that's the only thing that's going to take the pain away on a permanent basis.
Right. Yep, that's serious stuff. All right, our time is fast spent now, and I would be remiss if I do not ask this question. And I asked this question of a lot of our returning doctors or doctors who have worked in both parts, both the Western world and Nigeria, is that what have you seen? I mean, I'm convinced in many disease conditions, there's a difference between how blacks respond and how they present, and how, as opposed to how whites respond and how they present. Speaking about orthopedic surgery, for instance, I guess its colloquial belief is that blacks definitely have thicker, denser bones and are less likely to have hip fractures. The women, that is, are less likely to have hip fractures the way the white women do, because of the bone strength and bone density, and that applies to the teeth as well. What's your experience?
I think it would be a mistake to just make it a black-white thing. I think it's a strong bone, weak bone thing. I've seen weak bones in blacks, and I've seen weak bones in whites. I've seen strong bones in white folks, and I've seen strong bones in black folks.
Yeah, not
So
being political.
it's
Listen, this is
no,
not a
no.
political
I am
You
not
don't have
being
to be,
political when I
you
say
don't
that.
have to be diplomatic.
No, I am actually very, 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 very serious about it because
Okay.
what really determines these things are one, fundamentally the genetic predisposition of people. Are you predisposed to like losing your bone fast postmenopausally, for example, right? Are you
Yeah.
are you have you had chronic vitamin D deficiencies and maybe calcium deficiencies and you've not really built up a strong bony bank before you started to lose it, so you lose it a little faster, you know?
Uh,
Or do you have some disease conditions like rheumatoid arthritis that predisposes you to having some soft bone, especially when not well treated, right? Do you have
mhm.
other inflammatory conditions that could cause that? Do you have metabolic bone disease? So there's like a lot of different things that could contribute overall to some people developing uh, um, um, weaker bones than others. And
So
and yeah,
just to be clear, there's, as far as you're concerned in your practice and your experience, there's really
mhm,
no difference.
I've not really seen that difference. Absolutely, and the literature have not really shown it. So it's scientifically no.
Anything else you just want to quickly mention before we close today?
I mean, for people who want to seek our seek consultation from me, they could reach out to us at docmedng.com. That's docmedng.com. And we are on all the platforms on LinkedIn, Instagram, Facebook. You actually could go on our website and just book a consultation directly with me without having to call. So but I'm here to serve. I'm looking forward to seeing as many of you as possible. And it was important for me to come on this platform, on NTA, to have this discussion because I really believe in democratizing access to high quality care in a very dear country. The Nigerian patients deserve it.
Absolutely. Absolutely. Well, we thank you for your time today. And certainly what you're doing is a very noble thing. And I wish you and your family, I know it's not going to be hard. It's not going to be easy for your wife and kids to settle in a new place. But I believe with God's grace, it will be smooth. So thank you
Thank
once
you.
again. And folks, remember, you can join us anytime. All these videos are archived, brainandbodyfoundation.org. Till then, till next week, we shall say goodbye and see you soon. God bless. Bye.